As a professor of mine used to say, technology is great when it works.
That's right.
So hello, everyone. Thank you so much for joining us today. I know we also have some of our international partners with us today, so I really want to thank you for joining us as well, because I know time zones can also make life a little challenging. So thank you for making time in your schedules as well. I am Alexa Smith, and I am the International Partnerships and Programs Coordinator with the Office of International Programs. And it is my pleasure to welcome you to our 2022 International Educational Experiences Showcase, which we have not been able to have in 2 years. So it's nice to have this event back. So IEEs at a glance for this past year. We had one in the School of Health Professions. We had 20 nursing students complete a virtual experience with Child Family Health International, one of our amazing partners. And we had 28 students in the School of Medicine. Most of those were our fourth-year students completing their February rotations. However, we did also have some first-year medical students do a virtual rotation with Child Family Health International as well. And we had 14 residents go abroad as well. Now, we might say, wow, those are really small numbers compared to in the past, we would maybe have over 100 students annually go out. But I will tell you, getting this number to me is an incredible feat. I had quite a few IEEs that we had started planning for. I had students submit applications, and then heartbreaks of heartbreaks. Our partners said, actually, we have to cancel this because of the pandemic. So I actually had quite a few students who unfortunately were unable to go. So while these are smaller numbers in the past, I don't think I could be any happier, honestly, than the fact that we did have this many go out. Given all of the things that were working against us, I feel, just amazed that we got to this point. And so I thank all of our students for working with me, being patient with me as I was trying to juggle finding answers. So I know sometimes it really was a waiting process. So thanks for hanging in there with me. These are just the locations our students went to this year. As you can, and our residents as well, excuse me. I'm not used to including our residents yet. My brain will catch up, I promise. So as you can see, again, kind of a wide range here, which is always great to see. We have such a vast, amazing world out there, and I love knowing that our learners get to go and see things from a whole new perspective, either in person or virtually, because those can also be rewarding experiences as well. And of course, we couldn't really do this without our benefactors and their generosity and their graciousness in funding the experiences for our students. This year, we were fortunate enough to award over $78,000. And those funds came from Dr. Ivan Damyanov, Ms. Lou Loescher-Dunge, and the Ruth Bohan Trust. So we are just so appreciative of them and their generosity and allowing us to help our students from a financial standpoint and hopefully alleviate some of the burden, because we know international travel can be very expensive. And sometimes that can prevent someone from going on an IEE, and we don't want someone to feel that they are unable to go. So any financial support we are able to provide, again, we're just very grateful for. So thank you, benefactors, for your ongoing support. All right, so of course, it takes some people to make these happen. We have our office, we have Kimberly Connolly, the Senior International Officer, Arena Aris, our Associate Director, Stacey Rader, our Program Manager, and I think you've heard about this other person, Alexa Smith. You might have heard of her already at this point. And then of course we have our fantastic advisors for our students who help them, especially from the academic standpoint. For the School of Health Professions, for our physical therapy students, it is Dr. Yvonne Colgrove. In the School of Medicine, our M4 is Dr. Sarah Finatario Kessler. For KUMCIO, we have Dr. Dennis Allen, Dr. Michael Kennedy, Dr. Brandon Kennedy, Dr. Denton Shanks, and Dr. Margaret Smith. And for the School of Nursing, we have Dr. Michelle Cochran. So thank you so much to our faculty advisors for everything you do for our students. And now my pleasure to introduce Dr. Sarah Finatario Kessler. Dr. Finatario Kessler completed her doctoral training in international public health at the Johns Hopkins Bloomberg School of Public Health. Her active studies focus on developing, evaluating, and adapting health interventions like the HIV Infant Tracking System, or HIT system, to improve early infant diagnosis, EID, of HIV, prevent perinatal HIV transmission among pregnant women, and pilot new point of care HIV testing strategies at birth in Kenya. And now, Dr. Kessler.
Alexa, thank you so much for that introduction. And it's just, this is a nice time of year to kind of celebrate and recognize the fruits of all the labors of getting these IEEs planned, and the students and residents getting out there, having the experience, and circling back to reflect a little bit. And as somebody who has ended up making my career in global health, these early initial experiences, these IEEs, can take your life in many directions, and I think when we think about, what you gain from these experiences as a person, as an individual, as a future healthcare provider, there will be an impact that you can trace throughout your life. It may also start a complete cascade of events and opportunities that could lead you to a place in your career that you may not have ever saw yourself going. And I think we can say that, with a lot of experiences that we end up having. But I think we're grateful, and the team and OIP, Kimberly and Alexa, are so dedicated to this endeavor and offering this to our students and learners at KUMC, because we know that these IEEs really give us the opportunity as an individual to stretch our comfort zones, whether that's our physical comfort zones with different showering opportunities or temperature control opportunities in the places that we are, but our kind of mental comfort zones, our emotional comfort zones, as we find ourselves placed in navigating a different culture, which certainly gives us a chance to then reflect on our own culture and why sometimes that adaptation in different settings is difficult for us. And I think this opportunity to transplant and take ourselves out of our grind, especially I'm thinking of our medical students, that, and our nursing students, everybody, health professions, that day-to-day demands where you can really only think about what to do tomorrow and surviving that. And it makes it harder to have those opportunities where you can self-reflect about your own self, your space within your home life, your family life, your community, but really your place within a global community. And so if nothing else, if this IEE, is the first and last international experience that you have in this capacity, that's great too, because I think it does create a space to pull us out of our day-to-day and really give us a little shock to our system to introspect and reflect, which is really hard to do given the grind of our normal lives. So I know in reviewing the IEEs, at least the PowerPoint presentations, at least, for our medical students, I know that this opportunity gave individuals new skills, new clinical skills, an opportunity to observe things that they really admired in other settings, some things that they found concerning in other settings, and this chance to sit with that, think about how do they feel about it, and how do they take that knowledge or that experience and see, how to ask more questions, how to contextualize that experience and what it might mean for their future practice. But I think at the end of the day too, developing relationships, even if they were just the brief, for a couple of weeks while you were there, but having the chance to share with other residents that might have been in the setting where you were learning, other medical or other learners, preceptors, patients, maybe the neighbor the neighbors in the apartment that you stayed in. All of those opportunities where you're having a chance to connect with people in a different setting. I think that human connection and sharing of ideas is also, a unique and special part of this IEE. So I think seeing the role that this has played in my own life and so many of our colleagues, I'm just really grateful that KU Medical Center really offers these range of opportunities, including the new virtual opportunities. This is exciting for all of our community here. So I think with that, we're really looking forward to getting to hear some highlights from our students and hear this at a bit more personal level from some of our KUMC learners. So thank you all. It's really exciting, and as we continue to grow this program here, and a big shout out to our OIP team.
Thank you so much, Dr. Kessler. We really couldn't do it without you. And now the winner of our IEE photo contest is Skylar True from the School of Medicine. His photo is titled Estudiantes de Medicina, and he was in Medellin, Colombia at our partner Antioquia. And he captioned his photo, "Between seeing patients and charting, medical students may have the good fortune to find time for coffee and a snack at the shops across the street from the hospital. It's easy to relate to one's counterparts. We all know the grind." So really tying back into what Dr. Kessler just said, talking to other students that are at the location where you're at, you can make the connections and really get to know people and find out that you have far more in common than you realize. So this is a great picture, and we're excited to have it as part of our IEE collection, and we will be getting Skylar his prize. And now the moment you have all been waiting for, our podium presentations. We have 4 presentations today. We have Leslie Lesor in the School of Health Professions, the Department of Physical Therapy, the School of Medicine, Emma Beck and Hannah Hildebrand, and in the Department of Plastic Surgery, Chief Resident Dr. Katie Eakin. All right. So Leslie Lesor is a final year Doctor of Physical Therapy student, and she spent 6 weeks in Belgium, and she was our first student to go out this year. So
all right, thank you so much, Alexa. So good to be here. So yeah, I went to Ghent, Belgium. I was there for 6 weeks. It was truly a great experience. Alexa, you can go ahead and go to the next slide. So Ghent is located in the northwest region of Belgium, so right up there, closer to the northern border. So the northern part of Belgium is referred to as the Flanders region, and then down southern is where the Wallonia region is. So we were up in the Flanders region. They all speak Dutch there, but the locals all call it Flemish. It's still Dutch, but they throw in a lot of French words, and there's kind of a different pronunciation with that. It's truly a gorgeous city, a lot of medieval architecture, very historic. So it was really great to do a lot of sightseeing while I was there as well. So you can go ahead and go to the next slide. So I was at the University Hospital in Ghent. It's a public research university, and it's one of the largest in the region. So I was in inpatient geriatric rehab. So we saw a bunch of different patients, post-op joints, neuro, post-COVID, amputations, oncology. It seemed like we were seeing a lot of post-COVID patients here. So a lot of endurance issues with the patient populations I was seeing. A lot of different languages spoken. I would say about 50% of the patients didn't speak any English. It was mostly Dutch. So there was definitely a language barrier there. So the rehab was quite a bit different, honestly, than what we do here in the States. So they have just one big gym, and the patients would come in and they would do a circuit style training. So they would spend about 20 minutes on each portion of equipment in the gym. And then they would do mobilizations, gait training, different machine work. Whereas here in the States, we're almost always one-on-one, especially in rehab. So that was very different for me. You can go ahead and go to the next slide. So the Belgian healthcare system is very good. According to all of the locals and the patients I worked with, they're like, it's fantastic. So they have mandatory health insurance covered through Social Security. And then because they're not dealing with those insurance companies, documentation is really mostly unnecessary. The only time I ever saw them documenting was really just giving summaries of patient care to give to the rest of the team members. And they also had a lot less objective measures because they didn't need to submit that to insurance. So that was interesting because we do so many objective measures here in the States. And then also the patients can remain in the hospital for as long as necessary. I had one patient who had been there for over a year, which was insane to me. They just didn't have a fear of hospital bills. There was just no rush to go home. So if they wanted to stay there, like sometimes they were just like, I feel like I need more rehab. So they just stayed there during the week. And sometimes they would go home on the weekends for like a trial period. Okay, next. And then here I'll talk a little bit about physical therapy specifically. So they use a lot of passive range of motion, which we do here as well, but they used more what we call CPM machines. So just like passively moving the joint. And they used passive range of motion for almost every patient, regardless of the diagnosis, which is pretty unusual for here. And the therapy was actually a lot less structured. The patients would kind of just come into the gym whenever they wanted to, as long as they got their like 2 hours or so of therapy in a day. And that was pretty much it. And then they'd also have a lot more independence. They would just walk in without gait belts. That never happens here. We use a gait belt pretty much for everybody. So it really shocked me the first day when they all just kind of like waltzed into the gym and without a gait belt or anybody walking with them. So yeah, much more independent, more mobile because they're also a very healthy population. And then as far as assistive devices go, they use a lot of forearm crutches, which we do not use much of that here at all. We use the axillary crutches. And I think the forearm crutches are actually really great. They're much easier to use. They're more versatile than the axillary crutches are. And they also use rollators more than just regular walkers. Okay, next. Just some other takeaways. The Belgians are very active. They ride bikes everywhere. They walk everywhere. They're very hardworking. I never had issues with compliance with them. There was never a time when I'm just like really had to convince someone to do therapy. They were just willing like immediately to do it. So they all worked really hard. They just wanted to go home. It always felt more like a community feel there as well. They often had multiple patients to a room. They were always doing group therapy in the gym. The patients would cook for occupational therapy and they deliver food to other rooms for other patients. So that was really cool. And then also just once again, the rehab length of stay, just more autonomy and just not rushed out because of insurance like we have here in the US. And then, yeah, once again, the language barrier, just speaking English was sometimes hard with the patients. I tried to pick up some Dutch, but the pronunciation was a little difficult for me. So even if I did know a couple words, it was still kind of hard to communicate. But all of my coworkers did speak English. So it wasn't too bad of a language barrier there. Okay, you can go ahead and go to the next. Just a little bit about COVID. I was there right during the height of Omicron. So a couple weeks into my rotation, pretty much 75% of the rehab unit contracted COVID. So we had to shut down the gym and then see patients one-on-one isolated. So that was definitely different for a couple weeks. And then their healthcare workers were N95s at all times. There were also a lot more COVID measures than there were here. So everything closed really early and you pretty much had to have proof of vaccination to go anywhere, to eat anywhere. And then it just seemed like there was a greater mass compliance there in Belgium. Okay, you can go to the next. Okay, so for my profound clinical experience, I worked with a Belgian man who had a leg amputation. He didn't speak any English, and I really struggled with my Dutch. And so I would try a couple words, but it was mostly like we weren't communicating verbally. But we were still able to laugh together so much. Like we were able to communicate non-verbally. So it was just a really great experience, kind of getting to understand each other like non-verbally. Okay, you can go ahead and go to the next slide. And then just cultural, really just getting to live like a local Belgian was really great. The cities surrounding Bruges, Brussels, was really gorgeous. The bakeries were my favorite, amazing pastries. And then also just, I have a picture of my neighborhood there over to the right that I lived in. And then, okay, you can go ahead to the next slide. I think that is it. There's a couple of pictures from my trip. So you can see the architecture is just beautiful. So, okay, I think that's it. Does anybody have any questions for me?
Hi, Leslie. This is Kimberly.
Hi.
I just wanted to congratulate you on being our first student to go out during the pandemic. So wonderful job. We know how much tenacity and just kind of trust that took to get everything organized and get the COVID test prior to leaving and coming. So congratulations. I did want to, and you actually talked about this as your profound clinical experience, and I'd written the note at the beginning, but can you tell me a little bit more about having a language barrier experience? Like you did say this was your most profound clinical experience. So like, how did it really feel? And how will that inform your patient care of someone who maybe doesn't speak English as their first language?
Yeah, that's a great question. It was a lot more difficult than I was expecting because everybody's like, oh, Belgian, like everybody speaks English, like it's fine.
Right.
And when you get there, it's like all of the coworkers, they're not going to speak English around you. They're all speaking Dutch. And so that was really difficult being, especially in group settings and not understanding, like I could pick up on little stuff, but it's hard to join in on that, like group conversations. And then yeah, with patients, it could be incredibly difficult. It was a lot of just demonstrating, using very short words and phrases. And I think that comes back into my future clinical practice and experience as working with other people, patients with language barriers or just other sort of deficits that they have, being able to kind of alter my communication style, use shorter words and phrases, using more nonverbal language. There are ways that you can communicate even without that verbal language. But yes, it was a lot more difficult than I was expecting for sure.
I bet. Yeah, that's amazing to have to navigate that. And I commend you on your success. And I also commend you on just, being in the moment and having that experience so that you can carry that forward into your practice with patients. I think you will find that will probably really be your most profound experience, long term. So yes. Congratulations.
Thank you.
Does anybody else have a specific question for Leslie? Please, you can unmute yourself if you're shy or for some reason can't unmute and you want to put questions in the chat. That's also possible. I'll be monitoring the chat. If nobody's going to unmute themselves, then I'll be selfish and ask another question, Leslie. You'll find I always have lots of questions. You mentioned the autonomy and the community and the health insurance. And I was kind of curious, like how, just your thoughts on the different system, not having to file insurance, the insurance not being, so that universal healthcare, right? Having that universal healthcare. Can you just share a little bit more of your thoughts about that system and maybe, the pros or cons that you experienced?
Yeah, I experienced mostly pros. It just felt like there wasn't that pressure. I feel like here when we do rehab, we have to get our patients out. It's usually within like 2 months, usually. And so we were seeing patients who were at a higher level of functioning. So they could technically go home, but the fact that they could stay and still get the help they need, even though technically like they're good to go home, I think is really great that they're still able to get that care. And then they're not paying for anything outside of, they don't have to worry about like $100,000 bill when they get out of the hospital. So there just wasn't that pressure. There's less stress. I think with that, yeah, it's pretty amazing, the differences, honestly. And I think documentation, not having to document as much makes it so much easier to provide good patient care, because you're not stressed about going and spending like 20-30 minutes after you see your patient to document everything that you did. So I think it elevates patient care as well as it making it easier on the patients.
It's such an interesting observation. And I wonder if there's been research done on burnout relative to specifically all the paperwork that has to be done, the documentation, and how much that contributes to burnout, you know, in our system, right?
Absolutely.
So overall, we know the less stressed people are, you know, that also contributes to their well-being and to their healing. So we know that that's a positive. Can you talk about the community feel just a little bit more? To me, that is such a tremendous difference too. And so can you just say a little bit more about how that felt to you?
Yeah. So here in the States, it's very individual. Like you take your one patient, you go, you do your exercises and you go back. But yeah, we would have just the whole gym was filled with patients. They had music on. They all got to know each other. They all had a roommate, so they got to know each other that way. Yeah, and it felt like the therapists were all, you know, interacting with the patients more. Like I kind of said, they would cook and they would give food to each other. Yeah, it just felt like way more like a community there than it does here, which I thought was really great, because I think we really lack that sometimes. It can feel very isolating for a lot of patients when they're in rehab here in the States.
Leslie, I mean, I realize you're just a student, but do you see like any potential long-term ability to like somehow impact how we do that here, to like somehow bring more community into your work?
Absolutely. Yeah. Sometimes it is difficult though, just because of the stresses of the day with documentation and whatnot. But I do think there's potential for growth, especially in something like rehab and just getting more patients involved, like interacting with each other. Absolutely. I think that's really great. It's something to think about for sure.
Well, thank you so much. Dr. Colgrove, you must be so proud of your student. Do you have any comments that you'd like to, or questions?
Usually I do my own personal debrief when the students come back on campus. So I do have a whole list of questions for Leslie later. But yeah, I'm glad she was our warrior that went out and was adventurous enough to push forward with doing an international experience when everything opened up. So, and it sounds like she had a tremendous experience.
Thank you. Well, thank you, Leslie. We appreciate you so much. Great presentation.
So thank you so much.
So now we are going to move on to our next learner. Emma Beck is our next presenter, and she went to Columbia, which she will tell you more about. She's a final year medical student, graduating here very soon, and she's on the Kansas City campus. Thank you, Emma.
Yeah, thank you. Thanks so much for inviting me to speak. Yes, my name's Emma. I went to the University of Antioquia in Medellin for 4 weeks with 2 other classmates, and we had a phenomenal time together. So yeah, go ahead and go to the next slide, please. Thank you. So these are the competencies that I wanted to address in my presentation. So identifying the major causes of morbidity and mortality in Columbia, even like within Columbia, the different patient populations, evaluating the social determinants of health and wellness within the community and country, and kind of comparing to the United States. And then in that same vein, thinking about health disparities and how they're parallel to the United States and some different things about them. And finally, barriers to healthcare, specifically in a particular resource setting, maybe a little lower, and kind of what I noticed about that. The next slide, please. Thanks. So a little bit about the region of Antioquia, which is where we were at. You can kind of think about it, I guess, like a state of the country. So there was a medical doctor, Hector Abad Faciolince, several decades ago, 50s and 60s, and he was responsible for developing infrastructure for potable water, as well as like standardization of pasteurized milk in the state of Antioquia, which is huge because that is one of the only areas in Colombia where you can just like drink tap water. So that was really cool. Definitely a lot of disease prevention that came out of that. And this Netflix movie called El Olvido que Cedemos is a dramatization basically about his life and contributions to the community and to public health. One thing that we learned about was how the students and faculty at the University of Antioquia have been involved for several decades in bringing about change in the country for the betterment of the citizens, and have been very politically involved. So that was also a big contribution to the health of Antiochians. Additionally, every Sunday they shut down several of the major roads and allow people to use it for biking. So Sunday morning, our first morning was a Sunday, and we just saw like hundreds, more than hundreds probably, of bikers getting their exercise in. They also close other roads on the big hills in the city, and people will run up them and do hiking. So it's a really neat initiative that Medellin has undertaken to encourage a healthy lifestyle, as well as just access to fresh produce everywhere you go. And these gimnasios de aire libre, which are basically just like outdoor gyms, if you think about LA on the beach, and they have basically adult play gym kind of things, like parks. So that's kind of what they've got going on. And that was really neat to just be on a walk through the city and you see a bunch of people just working out at the free gym outside. And I mentioned some of the parks, and then I will touch just a little bit on COVID-19. They have similar struggles with vaccination in rural areas, but in the city, most people were vaccinated. And then because it was crowded, masks were pretty much everywhere. So yeah, so it was actually kind of impressive coming from some of the rural areas in Kansas down to Medellin and seeing the difference there. Next slide, please. Thanks. So like I said, I wanted to talk about morbidity and mortality. The top 10 causes of death in Colombia are listed here with one asterisk. These are diseases or problems that are directly related to tobacco use, which was something that we noticed and were kind of surprised by, was how many people were smoking, especially even like the young population. So we were a little bit taken aback by that. So ischemic heart disease, stroke, COPD, and stomach cancer. And of course, tobacco could play a role in these other things, but the ones I annotated were, strong correlation. And then interpersonal violence and road injuries are totally preventable, and really sad reasons to have so many young people dying in the country. And finally, I wanted to point out lower respiratory tract infections and stomach cancer, which are associated with treatable infections. In particular, stomach cancer, which I'll talk about in a little bit, but that was an interesting experience for me to see how much stomach cancer there is in Colombia. Next slide, please. Thanks. Talking a little bit about healthcare access and preventative medicine and chronic care management. They do have a national health insurance system. Anybody who is employed is eligible and is insured through that. So similarly to Leslie's experience, the majority of people were insured and they received that through the government. They do have great systems and guidelines and programs for children, especially, and also for annual adult visits, chronic care for folks who have, multiple comorbidities to have more regular contact, and then also cancer screening and early prevention or early diagnosis and prevention. So unfortunately, though, other than kiddos having good contact with the healthcare system for vaccines and tracking growth through their schools too, for a lot of adults, because for whatever reason, they don't really access the healthcare system. So when I asked some of the surgeons that I was working with and other medical students, why that is, they always said, there aren't really that many resources. So even if somebody wanted a screening colonoscopy, it would take them like probably a year to get one. And as far as getting into the doctor's office to like get screening labs, it takes so long to get in that most patients just kind of don't really bother doing it, or they don't see the importance of doing it. So that kind of resulted in particular, again, important thing that I saw because I was working in the surgery team was a lack of screening colonoscopies and how that led to just a lot of colon cancer. So if we could go to the next slide, please. So like I said, I was on the surgery team at Clínica León, which is the name of the hospital. Antioquia, University of Antioquia has multiple hospitals in the city. So the three of us were all at Clínica León. It's a pretty large hospital, 3 buildings connected. They have, I was personally taken aback by how excellent the surgical resources were there. With laparoscopy, they even have, this is ERCP, is CPRE in Spanish, is ERCPs in English. So sorry, I forgot to change that to English, but they have a lot of subspecialists, and interestingly, organ transplantation in Colombia is kind of the opposite of here. Rather than opting in, everybody is presumed to be a transplant donor. So, or an organ donor. So you have to like specifically opt out if you don't want to do that, which is probably one of the contributing reasons is that there are so many like motor vehicle accidents, especially with young people on motorcycles. And so they kind of just made that law change and had a subsequent like drastic increase in transplants that were completed. Next slide, please. Thank you. So my clinical experience, like I kind of mentioned earlier, just how taken aback I was by the prevalence of GI cancers, which obviously we have a lot of GI cancers in the United States as well. But between the endemic status of Helicobacter pylori, which is a bacteria in the stomach that can cause, that is like a risk factor specifically related to stomach cancer, and smoking also that I talked about. So I saw a lot of people getting their stomachs removed because they had stomach cancer. And that was kind of shocking to me. And then also colon cancer that was at advanced stage at the time of diagnosis. It was kind of hard to compare some of this data that I found in Colombia to the United States, but basically there's a delay in getting a colonoscopy that we kind of talked about. So by the time a patient presents to the doctor with the symptoms, like of colon cancer, and then by the time they can get a colonoscopy for diagnosis, and then from the time they diagnose to actually treating with surgery or chemotherapy, is delayed compared to the United States. And the surgeons expressed quite a bit of frustration at that, and a deep desire for better access for screening colonoscopies for early detection. So that was another thing that was really problematic at that hospital and throughout Colombia in general. Next slide, please. Oh, sorry, actually, can you go back? Sorry. The pictures, that's obviously not, I'm not doing anything to anybody's colon, but they took some pictures of me in the OR. I was helping to sew up after they took out a ganglion in somebody's neck. So, okay, next slide, thanks. Okay, as for cultural experiences, we had a really, really awesome time. I was so glad I got to go with other classmates and we could share these experiences together. The University of Antioquia has it's kind of like a friendship program for student ambassadors for international students. So they showed us around the university. They talked a lot about the history of the area. And then there were some activities to get to know other international students as well as some local Colombian students to help us kind of get to know the city. So that was really cool. We were really thankful for them. They have a lot of museums. One of their famous artists from Colombia is Fernando Bortero, and he has a lot of work throughout the world. And several of his sculptures are just throughout the city. So as you walk around the city, you can just see a lot of sculptures and it's really cool. A lot of people have heard of Comuna 13, which is a really good, like, it's just really good, cool story of like revitalization and how the locals really took control of, yeah, I mean, some like not great things that were happening and decided kind of to change their own destiny and now have a really vibrant art community there. So if you ever find yourself in Medellin, I would recommend going down there and seeing that. And then we also went to Jardín, Antioquia, which is another city or kind of town in a rural area. So we learned about agritourism, the coffee economy, and we did quite a bit of hiking. So we had a great time. Next slide, please. As for the impact on my future practice, I did speak Spanish before I went to Colombia, but Colombian Spanish is very different than the Spanish I'm used to speaking with patients. And I also realized how important it is to have like daily integration of Spanish to maintain the ability to communicate well with my patients. I also noticed, I don't know why it was kind of surprising to me because there are a lot of cultural differences in the United States between urban and rural areas, but just, yeah, paying attention to just how each patient is unique. Basically, each person is unique, and just knowing, you know, what country they're from or whatever doesn't necessarily inform everything about their culture. So just really paying attention to them and to what's important to each patient. And then also having an awareness and knowledge of epidemiological risk factors for each patient. Like I said, you know, with the H. pylori and the smoking, those are, especially the H. pylori is a little bit unique, that is regional. So I definitely understand now how important it is to know about that. And then one thing about resources in rural settings or in maybe low resource settings is almost just to like not accept that like, oh, we just don't have that here. But for me in the future, I would really love to like live and practice full time in another country and in a lower resource area. So one thing that I kind of took away from my experience is, you know, just because something isn't there now doesn't mean that I can't be a part of making that happen. So yeah, those are some things that I think will impact my future practice. And then next slide, please, and my references.
Thank you so much, Emma. Great presentation. Great. Very, very thorough. We're proud of you. So Emma, I'm going to start the Q&A with you. And first, I'd like to say that obviously I've experienced with you through your involvement with Partners in Health. And so I know that you already came into this with this great interest in global health and social determinants of health. But I'm still just curious, like, you came in, you've had this interest. This is definitely just part of who you are and kind of your journey. But how did this kind of maybe even elevate that or catapult you even more into, like you said, your desire to do this professionally, perhaps, you know, work and live outside in another country and practice?
Yeah, great question. I would say it just reminded me again, because the last time I was able to go out of the country I went right before COVID to Guatemala, but that was like kind of a 5-day deal, which is not bad, but like this was the first time in like 5 years I was able to have an extended period of time outside of the country. And it, yeah, really did just remind me how important I think the work is, and also reminded me about how excellent and yeah, just how great like the medical staff is in other countries, and how much there is to learn from them. So it really just made me more excited about the future of learning from colleagues who practice medicine in a different way than I was taught, because they have different skills. So I don't know if that really answered your question, but it just made me excited about getting to work with people from different backgrounds.
Absolutely. And Emma, I just want to say how much I appreciate what you just said. You've always really come from that position of, mutualism and collaboration and learning from others. So thank you for stating that, and how that is what draws you to the international work, is your interest in how other people are doing things and what you can learn from others who are doing it better. I really appreciate you for that, and your words matter, and you're always very good in how you phrase your interests. So thank you so much for that. Do you know, with your residency program, will it afford you an opportunity to spend maybe more time with partners? Can you speak to that?
Yeah, so I will be going to Via Christi for family medicine in Wichita.
Yeah.
And yeah, I know, super stoked. So in my third year, I'll have a chance to do a 1-month international rotation.
Yes, you will.
So I am excited about that. As for kind of, but Wichita does have a pretty rich international community there. So there will be plenty of opportunities, I think, to continue to grow in this area, even when I'm not able to get out of the country.
Very, very true. A lot of our residents who go out for IEEs come from Wichita. Just a very strong program, and like you said, just a great community of immigrants and different cultures and ethnicities in Wichita. So wonderful. Dr. Kessler, did you have a question for Emma?
I do. Thanks, Emma. I really liked your comment at the end where you said, just because a service or strategy or technology doesn't exist now, doesn't mean you can't be part of bringing it there. And I've been working in early infant diagnosis in Kenya, where we had to wait till 6 weeks to do the PCR because of resource constraints. But when point of care testing was first introduced in 2016, it was like mind blowing. It was so exciting. And we were part of that pilot introduction. Is there anything that sticks out to you in your mind from your experience in Colombia that's like, if we could just find a way to get X, Y in this setting, what would it be? And of course, I'm imagining you would enjoy being part of bringing that. So anything stand out to you?
Yeah, I would say if I'm thinking like strictly in Colombia and what I saw there, again, I was part of a surgical team, and I'm not going to be a surgeon, so it's like probably a little bit different for the rest of my career. But I was just thinking, how great it would be if they were able to have like an entire, I don't know, like we have, there are like surgical clinics. You can go in there and do like your same day surgery. So if there was like just an endoscopy clinic, and there were a bunch of surgeons who, rotated through there, and they were like, yeah, all we do at this place is everybody gets their screening colonoscopy, or even with H. pylori, like their EGD for sampling to test for H. pylori or something. So, I mean, that's like kind of a very like big vision kind of thing, but but just as far as even just thinking for my own future personally, I was like less excited about getting scope training, because I was thinking, oh, I'll be in low resource areas, like they don't really have that, but now I'm like, well, it would probably be a great skill to learn, something I could offer to my patients in the future, and maybe be someone who helps teach that in the future.
That's great.
Great. Thank you.
It's interesting, Dr. Kessler, because when Emma was speaking and she was talking about the lack of early detection and diagnosis for, colon cancer, I thought of you, and also your work that you're doing in Kenya with cancer and trying to have earlier detection. So there's definitely some synergy there. And it's great that Emma will be in Wichita with us, so we can continue the relationships and conversations.
Yeah, absolutely. And Emma, those kind of system level modifications that could have the potential to then see so many people quicker, faster, earlier detection, maybe less burden on the travel that they have to take to come in, like all of those kinds of real life things. I like that you are thinking in that kind of system strategy way too, in addition to the clinical benefit. So yeah, excited for your future work. Thank you so much. This was great.
Yeah, thank you guys.
I'm going to go a little off script here because I know Skylar was in Columbia as well. We're going to have plenty of time at the end for other comments and questions generally for students, but I did want to ask Skylar if he, if there was anything to add right now or at the end, certainly chime in then, just perspectives and experiences. Sorry to put Skylar on the spot, Skylar, but by the way, loved your photo. Thank you for your submission.
Oh, no, I had a really great time traveling with Emma and Catherine McGregor. We all had just awesome time in Columbia. It was really great. I agree with everything that Emma just said. It was my favorite experience in medical school, definitely.
What was your most significant clinical experience, Skylar?
I would say bonding with fellow interns. They call them internos, even though we reserve that term for people who are graduated from medical school. But making friends with people who are in the same shoes as us, getting ready to graduate from medical school, hearing their stories, hanging out with them. We actually cooked American breakfast for dinner for all of them. So it was very, very special to because I went to Guatemala with Emma too, and in Guatemala it's just you and Dr. Mendez, and in Colombia it's so nice to be able to create those relationships with people who really are same age, same anxieties, same hopes and dreams. That was very special. I'm just so grateful that we were able to go to Colombia and get to know these people and the relationships that I hope to continue.
Skylar, I really appreciate you and Emma bringing this up, because one of the things that we've wanted to do is somehow connect our incoming students, international medical PT students with current students. And it's really challenging because of student schedules. I'd be really interested in maybe some of you, all of you as students telling us, would there be an interest and how could we have some student ambassadors? Because we have students who rotate at KU, throughout the year, from October through, June. And so in your mind, is it possible for us to provide some of those experiences that you have?
I think so. I think so. The whole program that the University of Antioquia has is based kind of in for us, it would be the undergraduate. So there were only, most of them were not healthcare related people, but it was still excellent for the culture, to get the culture of Columbia.
Okay.
Yeah. And then as for the medicine, it was just kind of chatting in between patients. So I think a lot of stuff is just interpersonal. And that part, those relationships weren't really program based. It was just hey, let's go out and grab some food tonight or something.
Gotcha. It was more organic in the moment. Okay. All right. Very helpful. Okay. I'm going to pass it to Dr. Kessler to introduce our next speaker, and we can continue these conversations after the presentation.
Okay, what a beautiful picture. I love this. Next, our speaker podium presentation is from School of Medicine in Wichita. And I know we were just talking about all the great opportunities in Wichita and having Hannah Hildebrand with us to be able to talk about her IEE experience. She's in her final year of medical school at Wichita and had the opportunity in February to spend 4 weeks in Kenya and went with a nice sized group of fellow colleagues and students. So Hannah, thank you so much for presenting today for us about Kenya and your experiences there. Thank you.
Thank you so much for that. Welcome, Dr. Kessler. And yes, I traveled with a great group of other KU Med students. And if any of them have any corrections or additions to my presentation, feel free to jump in. Yes, so I was in Nairobi, Kenya for about 4 weeks, and you can go on to the next slide, please. Just some information about Nairobi and Kenya as an entire country. Kenya's population is around 54 million, and Nairobi houses about 4.5 million. In the entire country, there's 42 different tribes, and that equates to 42 different tribal languages and cultures and histories and backgrounds. So it's a massive conglomerate of people, all under the same Kenyan roof. There is a national language of Swahili. So everyone that we met spoke Swahili and usually also spoke a tribal language, and they were taught English. So if anyone probably that we met that wasn't in the an older adult was speaking fairly good English as well. So everyone was speaking about 3 languages. Just to give you some background on their poverty level, over 35% of Kenya's population live on less than $1.90 per day. So poverty is, of course, a massive problem in all of East Africa that I know of, and specifically in Kenya and Nairobi. Go ahead and go on to the next slide, please. So myself and the 5 other KU Med students did the bulk of our rotation at Kenyatta National Hospital. And that's a university hospital. It's an 1,800 bed referral hospital. So the patients that we were seeing were very sick, and were usually referred from smaller community-based hospitals. And it was quite a process, right? You go, you feel sick, you go to see your local provider maybe, and then they refer you to a community hospital, and then eventually you make your way to Kenyatta. So it wasn't a quick, streamlined process for sure for a lot of these patients. Because it was a public hospital, all of their resources were either given from the national government or some corporation donating supplies, or and then there were also residents and medical students who trained at this site. I can't remember, but we were mostly working with the OB-GYN department, and they had like over 100 just OB-GYN residents. So they're really, there's a lot of trainees working here. And a lot of the care was given by either students or residents at that site. You can go ahead and go to the next slide. So the main topic I wanted to cover was the barriers to healthcare delivery and how these influence access to quality of care in Kenya. And the reason I'm so passionate about that topic is because inequity and limited access to healthcare is universal. We see that here in Kansas, you'll see that in Kenya, you'll see that in Western Europe, you'll see that in Asia. There's barriers to healthcare everywhere. And what I'm really interested in is kind of more of the public health aspect to that. What causes those barriers? What are the upstream effects? Because it's easy to see a patient in your clinic and be like, oh, you live 4 hours away. How can we get you here? Or why don't you understand the healthcare plan? And when it's really education, or so there's all of these massive causes and systemic issues that causes barriers to healthcare. And I wanted to learn more about what that looks like in Kenya. You can go ahead and go to the next slide. So specific barriers to healthcare that I wanted to learn more about include the lack of education or misinformation that many people in Kenya had when it came to healthcare and providers. There was also limited physical access to provider or facility, no streamlined process to get to a hospital, difficulty with the roads and traveling to a referral-based hospital. Finances, of course, were an issue for many patients. And then medical resources as well, working with no ultrasound, or maybe fewer like sutures or worse surgical supplies. So that was something that I witnessed in Kenya as well. You can go to the next slide. So examples of these barriers to healthcare. Like I said, I worked a lot in the OB-GYN department, and pregnant moms did not know the signs and symptoms of preeclampsia, headaches and swelling and edema in the lower extremities. Moms were not educated on those early signs of eclampsia or preeclampsia. So what we were seeing in Kenyatta were really, really severe progression of symptoms, where they were having seizures, cerebral edema, and many women were, they only came to us after they had already had a seizure. So the interventions that we could do were very limited. And these women, most of the women that we saw in the maternal ICU were having no change in neural behavior after 14, 20 days in the ICU. So really long-term problems after progression of their symptoms. Distance from Kenyatta, patients had to be referred through community clinics and providers, and then travel many hours just to get assessed at Kenyatta. In Kenyatta, so patients were just coming after severe progression of their symptoms again. Financial burden, many patients would procrastinate seeing a provider due to inability to pay. And then while Kenyatta was a community-based hospital, or sorry, a public hospital, it was fairly well known that the private hospitals in the country gave better care, but they took cash, and if you couldn't pay for that, then you were left going to those public hospitals. That might give a little different care. And then, like I said, limited medical resources. We were seeing women go through labor without any ultrasound or continuous fetal monitoring. I saw residents struggle to close abdominal surgeries due to limited sutures, and they didn't want to take up too much suture. So that was something that you don't see in the States. You can go ahead and go to the next slide. So interventions to these problems, this is really hard, of course. And if it was easy, it would be done, right? So education, that's difficult because you want to utilize the community members, because people aren't going to learn from me coming into a community and saying, oh guys, duh, this is what the causes of maternal eclampsia, and come see us early. So there's got to be a community-based educational system that community leaders can share the responsibility for educating their community members. Distance from Kenyatta, that's an infrastructure issue that can be combated with increased resources and number of outreach facilities and providers. Financial burden, that's a huge systemic issue that is so multifaceted. And then limited medical resources, that requires increased governmental funding and a greater corporation involvement. You can go ahead and go to the next slide. So in summary, this is a really complicated issue, and the specific causes of inequities in the healthcare field can be found far upstream in governmental and systemic systems in place. Go ahead and go to the next slide. This isn't even a picture of me. I didn't get a lot of pictures in the operating room. Sorry about that. This is my friend Emma and Gabby. I think they were doing either a cesarean section or a fibroid removal. But my most profound clinical experience involves a cesarean section in a laboring mother. Labor is a very scary process, especially in a packed and busy labor ward that we saw in Nairobi, and women were wheeled back if they needed a C-section. And a lot of the times, because these operating rooms are so busy, no one's telling the patient what's going on. We're busy setting up the OR or busy prepping the surgical site for so many different reasons. So I was able to kind of hold her hand, and then I actually completed my first spinal block on her. And then I was first assist on her cesarean section, and we delivered a healthy baby boy. And then I was able to help suture her clothes all the way up to the skin. And I am not interested in OB-GYN. I don't think I'll ever deliver another child in my life, but this was one of those really impactful moments where I was able to go from start to finish in this woman's surgery and comfort her in all the ways that I could. You can go ahead and go to the next slide. My most impactful cultural experience. This is actually, Davy, I think you're on here. I actually don't remember if I saw your name. This is Davy's childhood home, and we were welcomed into his grandmother's home, otherwise known as Shosho. And that's his cousin on the left. And I think Davy's taking the picture. I don't know why he's not in this one. But Davy grew up in Kenya and moved to the States at 15. And so getting to go back to his area where he grew up was very impactful. And I don't know if you guys would ever know this, but his family and other Kenyans welcomed us into their home with the greatest warmth. And I'd never felt more invited into a home. And we were able to share tea and food and stories and walk around the neighborhood. And this was one of the moments that you travel for, right? You travel to get invited into someone's home and really learn how they live and learn from them and be able to laugh with them. So that was really impactful for us. And we were so excited to get out of the hustle and bustle of the city of Nairobi. And I wish I had put more photos because this home and this area were so beautiful. You can go ahead and go to the next slide. And that's my references. Thanks for letting me share today, guys.
Hannah, thank you so much. This was really great. And I remember reading about your clinical experience with the mother, and I could just picture the scene, in the midst of the chaos.
Mm-hmm.
And I am sure that gesture, that woman is never going to forget you either, because, in those moments when we're scared and need that support, I know also traditionally in Kenya, there's not a lot of pampering for the laboring mother, which I'm sure you observed. And so that just like appreciation for her emotional status at that time, knowing what her physical endurance had probably, I imagine she labored for many hours before she got wheeled in for that, so she has been through the ringer. So it just warms my heart and makes me smile to think of what you take away from that. And I guarantee she has gone home to tell her family about the blonde doctor from the US that connected to her in probably such a gentle way that, I don't know, maybe her, I won't go on from there, but I just think that's very special. And thank you. I guess I was also curious, and this is just, for Davy's family, and Davy, we're going to have you comment on here too. I know you said it was outside the hustle and bustle. Do you remember where in Kenya that was?
Lower Kabete, is that right? Am I saying that right, Davy?
Let's have Davy confirm.
Or anyone else from Kenya. I think that's right.
Yeah,
Here's
that's right. Lower Kabete.
Sorry, say that again, Davy.
Lower, I guess that's right. Lower Kabete. It's in Kiambu County.
Gosh, you're stumping me, David. I'm going to have to get out and I have a map on my wall here. So, okay. But I think it's so nice, like Hannah, when you said that is the kind of experience you travel for, and you could travel for years to a place and not have that kind of experience. David, did you have any comments about what that was like to, I don't know, the vulnerability or the connection of bringing in, merging your worlds like that, right? Your KU world and your family?
I think personally it was a very nice experience for everyone involved. My social was very happy to see them and have them visit. She kept talking about them days after they'd gone. She still asks about them, and she was very excited. So I'm glad they were able to come and visit and see the village. Yeah.
That was just very special because every person on that trip with you, Davies, commented on how special that visit with your show and with your family was so impactful to them. So thank you for sharing that with our team. Hannah, and I'll open this up for questions from others. I realize I'm totally hogging this. Apologies, guys. I wanted to ask you the same question about that time spent in the maternity ward. If you had a grant or you had a way to work with the Ministry of Health or the hospital administration there, was there anything that you just kept thinking about, like this could be so impactful if we could make this shift or introduce this technology or strategy?
Yeah. So many, right? Like I would love to say that everything would be fixed if I could just give, millions of dollars, right? Like if you gave the resources, right? But I don't think that would change so much because so much of the inequality is culturally based. Like these women, no one at Kenyatta receives epidurals. And that's kind of both, Davey, obviously, correct me if I'm wrong. I think that's both culturally and resource driven. I think a lot of women are educated that, you have to go through pain to have a baby. And that's kind of like the process of becoming a woman is going through labor. And that's something to be proud of. A lot of women didn't want cesarean sections because you got a spinal block. So you're taking the easy way out. So I think, and then I talked specifically to Davey about this. I was like, oh, everything would be fixed if everyone had access to birth control, because then you can pick and choose when to have a child and have a little bit more autonomy. And he kind of taught me or challenged me to think about more education-based changes. And okay, well, what does relationships look like? How do you teach sex education in these countries? Does everyone understand the dangers of getting pregnant and also how the labor process is? So I think education would be one of the greatest changes that you could make in Kenya or in these areas. And then if I could just give resources, I would give, I'd probably give continuous fetal monitors for moms in the labor ward, because you're laboring blind if you don't have a continuous fetal monitor. You do have those little ear things. I actually don't know what they're called, where you can stick it up to the mom's belly and listen, but that is by no means highly sensitive. So, and so women didn't know when they needed to get a C-section. It was really kind of up in the air if you got one. So that's probably would be the thing I would give the labor ward for sure.
I'd like to chime in here if you don't mind, Hannah and David, and those of you who were in Kenya. I know a lot of you spent time, in the OBGYN, area. So in that specialty, Hannah, I really appreciate what you said about David helping you see something from a different perspective, because we often think that because we've been taught something, that is the only way. And I come from having the experience of both worlds too, like David, being raised with a certain religion and appreciation of babies and we don't use birth control, which is not, supported by the normal American population. But the way my family and my culture and my religion is, we're really what's reflected in a lot of the world besides America, right? Where children are considered a gift from God and a blessing. And, we have a family of, I come from a family of 10, we have 9 children, and I delivered on the island of Ponape with no fetal monitoring, no any type of intervention, where all the women, as you described, they deliver a lot on their own. And they are also told, I was told by my mother-in-law at the time that I'm not going to die, so I didn't need to scream or make any noise. And I often tell people, oh, there is a large spectrum between dying and screaming. All the pain in between can be expressed. So I'm kind of making a long story out of a very, very good point that you made. And I'm just so glad, Hannah, that you saw that, we often think that, like, the way we've been trained and educated and think like, oh, birth control, that is the solution. It may not necessarily fit with the belief system and the culture of an entire society, but education is always something that we can always, hope for and bring to a conversation. So I really appreciate that. And I'm so glad that you were open to David and to his, his influence. It's such a beautiful gift, the experience that you all had.
Absolutely. I think that that's the reason why we choose to travel, right? Is to challenge our thoughts and our experiences.
Yes, absolutely. And to be open to that. Sometimes we don't even know we have to be challenged, right? It's just so much a part of who we are and how we think. And so those are beautiful moments, just really wonderful. I would be interested in hearing from anyone else who was in Kenya as well. Any other comments about their experience and anything in addition to Hannah's wonderful presentation? Okay. Nobody wants to chime in. I assume we have a few of them on here. Well, we'll have a few minutes at the end to specifically ask some questions. Again, Hannah, thank you so much for your great presentation. And I'm glad that this global health experience will impact you, even though this wasn't your specialty, that you see ways that it will impact your future.
Thank you.
And Stacy's going to introduce our next presentation.
Good Our next presentation is by our plastic surgery resident. She is chief surgeon, and her name is Katie Egan, and she has this recorded because she's in surgery today. Alexa?
Good afternoon. My name is Katie Egan, and I'm a chief resident in the Department of Plastic Surgery. This winter, I was fortunate enough to have the opportunity to visit Munich, Germany for a 3-week elective. Despite the Omicron surge, I was still able to attend this experience. Munich is located in the Bavarian region in southern Germany and is in close proximity to Austria and Switzerland. Munich is known as the cultural capital of Germany and hosts the famous Oktoberfest. My objectives for my time in Munich were to learn innovative thinking and approaches to complex reconstructive problems, to learn specific surgical techniques not currently offered at our institution, and to experience how plastic surgery residency differs in a European system compared to the United States. I knew that I wanted to use my elective time provided during our chief year in our department to travel abroad and to learn about a different medical system and way of training. When I decided where to go, I spoke with an attending from another institution who had recently visited Professor Milomir Ninkovic in Munich and had an incredible experience with this time. Professor Ninkovic is a microsurgeon who is known for being an innovative thinker and has pushed the boundaries on reconstructive techniques. Some of Professor Ninkovic's most prominent contributions to plastic surgery have been regarding functional muscle transfers for various surgical applications, including several techniques that are not currently offered at KU or even in the United States. Munich Clinic Bogenhausen is a 1,000-bed hospital, which is a tertiary care center and an academic teaching hospital. It is a center for burn care in Munich, and many of the complex reconstructions stem from caring for these patients, as well as being a center for trauma and urologic care. Plastic surgery is involved in the care of all of these patients at Munich Clinic, and as well provides care for cancer and general reconstruction patients. I spent 3 weeks at Munich Clinic working with Professor Ninkovich. I focused on seeing complex reconstructions, including functional muscle transfers and other techniques that I had not previously been trained on in the United States. I also was able to integrate into the resident team at Bogenhausen to experience the differences in residency training in Germany. My days as a resident at Munich Clinic were structured much differently than my days here as a resident at KU. Here, the day typically begins with gathering information from patients' charts around 5:30 in the morning and rounding at 6 before getting patients pre-op to start in the OR at 7:30. In contrast, in Germany, our days would typically begin around 7:45 with all of the residents and faculty meeting to discuss cases from the previous day and planning cases for the day, as well as discussing the current inpatients. The team would then split up and some residents would go to the OR and some would take care of the inpatients. The days would usually last until 4 or 5 in the afternoon when the call team would take over. Residents usually had weekends off, especially if they had call shifts, or if they had a weekend shift, they sometimes had weekdays off, as work hour restrictions were strictly enforced. A 50-hour work week restriction was in place for residents in Germany. However, the German government mandates that workers cannot work more than 40 hours, so residents were only paid for 40 hours weekly, and then they received a bonus at the end of each month if they worked over 40 hours. My experience in Munich Clinic involved experiencing several surgeries I had not previously seen in the United States. These included complex microsurgical reconstructions to treat burn injuries, cancer reconstructions, avascular necrosis, and traumatic defects. This picture shows an extended lateral arm flap that was used to cover a hand burn scar. Dr. Ninkovich, who I primarily worked with, had many years of experience, but still approached every problem with an open mind and was always looking for new solutions to problems or ways to improve surgeries and outcomes. I found the most interesting part of my rotation to be learning about the culture of training in Germany. In Germany, residency is treated like a job instead of an educational experience. Doctors who have finished medical training apply for an interview for open spots, and there's no match system like there is here in the United States. Residency is not a set amount of time, and it's completed when all of the goals for the residency have been accomplished and you have another job to go to. The residency and medical system is also very hierarchical, but the European culture allows for a slower workday. For example, one of the customs in the surgical departments was to sit in the boss's office in the afternoon and enjoy an afternoon espresso. I stayed with a host family in Munich, and my most profound cultural experience was when my host family took me to visit Dachau concentration camp. This was a chilling experience to see and experience the horrors of concentration camps, and to realize that this history is not very far in the past, and that we must continue to teach and learn lessons to prevent recurrence of historical horrors. In conclusion, because of the differences in how residents are employed and treated here compared to Europe, I felt that my residency has been more focused on my education compared to the training in Europe. In addition, the longer hours and rigor of the training here has made me feel better prepared for entering practice and better trained than the German residents. However, despite training being less rigorous, innovation and excellent surgery were still happening at Munich Clinic. I'd like to thank the Office of International Programs and my department for making this experience possible. And here are my references. And thank you very much for the opportunity to present today.
Okay, well, I wished that Dr. Egan was here to answer some questions, but I do appreciate her submitting a recorded presentation for us to hear her experience. At this time, I would like to ask all the students who completed international educational experiences to turn on the cameras. And we'd like to hear from more of you. Obviously, time doesn't allow in the virtual setting for everybody to present. So we focus on our podium presenters. We pick, Dr. Kessler and the advisors pick those who actually get to speak and present. When we're in person, then everybody used to give a poster presentation, and people would walk around so that every student got to talk about his or her experience. And it was really an enjoyable time for all of us. I feel pretty good that I think next year we'll be able to go back to that format because I miss that. I miss hearing from every single student about their most profound clinical experience, their most profound cultural experience. So at this time, I would ask anybody who had an international educational experience, if you would, unmute yourself, put your camera on, and then just share with us for you, the one tidbit. If you had one thing to say about your international educational experience, what would you like to share with the group? And just unmute yourself and share, please. Or I can call on people. Vincent, I see you. Hi, Vincent.
I would say my experience was definitely, really one of the best experiences I've ever had in my medical education and just life in general. I definitely had to go through a lot of loopholes to get into Thailand. That's where I did my international rotation. I rotated at King Chulalongkorn Memorial Hospital in their dermatology department. I had to quarantine for like an entire week in a hospital prior to like my arrival at the arrival into the hospital. And then, yeah, I mean, it was definitely worth it. Connected really well with a lot of the residents, medical students. The language barrier was definitely pretty significant there, especially with the patients, but most of the medical literature was in English. So I still thought it was very educational. One of the most educational rotations I've ever had. And yeah, definitely really worth it. If, for other people interested in international rotation, I would highly recommend it.
Thank you, Vincent. Typically we have our largest group of students go to Thailand. And in my closing, I'm going to comment a little bit more about this, but I would like to also just recognize how impressed I was with your just willingness to stick with it, because it was so complicated, to go to Thailand specifically. And you were just willing, you just had that, I can do this. And also I felt like you had the attitude that if it didn't go exactly as planned, that you accepted that, so it was a pleasure working with you, just seeing your attitude. And I'm so glad that you had such a tremendous experience, because Thailand is always such a tremendous experience for our students. So very happy you got to have that.
Yeah, thank you so much for the Office of International Programs for really working really well with me and being really flexible and helping me get there. So thank you so much. I appreciate it.
It definitely takes both, right? And we couldn't do it without your attitude either. So, so thank you. Let's see who else. Yeah, like I said, you can just unmute yourself, but I can also call on people if it's more comfortable. It seems like a little bit of a shy group. I'm surprised. Ryan, I saw you smile. So guess what? I'm picking you.
Yeah, I went to Ireland. There were 6 of us, 3 of us were in Dublin and 3 were in Wexford. We went kind of back and forth on the weekends, but we spent our weeks in Dublin or in Ireland, Wexford. And it was like a small town, relatively small town, but not small compared to our rural rotations here.
Okay.
So it was interesting to see. There was also a group of Irish students there, so kind of getting to talk to them about what their training is like. It's pretty similar in terms of rigor of their preclinical years, but in their clinical years, they really just kind of shadow. So they would kind of ask us questions about like, what's it like over there? And some of the ones who were planning to come to the US were talking about like step 1 and step 2 and stuff like that. So it was interesting to find their path, or hear how they do things there. And also residency training is different there in that they don't pick medicine or surgery like right out the door like we do. They get some time and they work in both jobs, so they can be very well rounded that way. And then the people, the town itself was a very kind of almost like a vacation town. It had beaches and stuff. They were small and it was 40 degrees, but it was pretty there, and the people were super nice. We had a neighbor who baked us bread and brought us like local cheese and butter, and took us out on the town and told us all the history of Ireland and of that place specifically. So people there are very proud of their heritage and very friendly. It was a great experience.
Fantastic. Ireland is such a wonderful country to go to. I know our Kenyan students talked about the hospitality in Kenya, and it is tremendous, but I also found that Ireland is the people are so warm, and the hospitality is at a great level, as is Belgium, actually, one of my other favorite countries for hospitality. Kate, would you like to share anything?
Sure. I think I went to Kenya as well. And I think for me, and probably all of us, it was a really good experience to have right before starting residency. I also have an MPH, and so I was really thankful to learn a different healthcare system. And I think it kind of relit that fire and motivation to pursue residency, kind of being a champion for vulnerable populations and the underserved, because we have that here as well, but also to one day maybe have a career in global health as well. So I think it was just really nice to have a few months before.
Great, thank you, Kate. Loza put and I hope I said your name right, a question in the chat that we touched on a little bit with Leslie. And I know, Vincent, maybe you can address this as well, because she asked about the experience when patients don't speak English or you don't speak their language. How is that? Did you feel like your learning was still, there? Was it a good learning experience, even if you didn't speak the language of the patient?
Yeah, like I said earlier, I think it was one of the best learning experiences that I've had in my medical education, especially since all the doctors and the residents, they spoke English. Like their lectures were like mixed in English and in Thai. But the patient population, it was difficult to interact with, the patients that I saw, especially if they were a little bit older. But I mean, I made a lot of friends outside, like in the community that spoke English. But yeah, I mean, I feel like for me with patient interactions, it was mostly observational, or I would have the medical student or resident or doctor would translate for me if I had to ask the patient questions. And yeah, I mean, I think with dermatology, it is a very visual field. So I still got a lot from, just being there in clinic and seeing, what they brought in and looking at things under the microscope and stuff.
Great. Thank you for sharing that, Vincent. Leslie, did you want to add anything on the whole area of the question?
Yeah, I was mostly with patients. They usually put me with the patients that did speak English, but for the ones that didn't, I still had a great experience. Yeah, either like through translation, or just, physical therapy is a little different because we can do a lot of demonstrations, so it might be a little different, but for the most part, yeah, it was still really good.
And of course, we talked about the impact as a healthcare provider, just experiencing that so you can relate better to maybe a patient who doesn't speak English in your clinic here in Kansas. Skylar, did you have any experience with that in Colombia, or are you fluent in Spanish and language wasn't an issue for you?
There's always more room to learn more Spanish, always. But actually, we did have a patient on the internal medicine service who was from the island of San Andres, which is in the Caribbean and owned by Colombia. but the people of San Andres, they speak Creole. So my attending was like, you should speak with him because like Creole has English involved in it. And I would be like, hello, my friend. And then like he would like respond to that. But I definitely, like there was some Spanish, some French, and some English. And it was still a lot of like smiling and nodding and pointing. So there's always more room to learn. We definitely learned a lot more Spanish there. And fortunately, happily, there was a medical student who was also international, but from Mexico City that we made friends with when we were there. And she would like relate to us like, oh, like you, even here in Colombia, like I don't understand like the Spanish that they're using. Like they call the stethoscope fonendoscopio instead of estetoscopio over there. Or they have this thing called equipo de órganos, which is like this little kit that you're supposed to carry around. So like you would understand the Spanish, but there's the cultural concept changes place by place.
Gotcha. That's very well described. Thank you, Skylar. Luke, what did you want to share with us?
So I went to Ireland. I was one of the students in Dublin. And I wanted to I've heard a lot about people just being welcomed into homes and that really being kind of the hospitality of the country being the driver and one of the best things they've experienced. And I would echo that sentiment. We had kind of the National Botanical Gardens and like a cemetery, like their city cemetery around, and I would just go walking through there because there were cool monuments. And one day I was walking through there and just an older man was kind of sitting there and struck up a conversation with him. And, you know, he gave me like a history tour through the cemetery, and it was really eye-opening just to see how important their history is to them. And it's really a pretty young country just as far as like independence goes for them as well. So the pride of their history was really cool to see. And also language barrier, you know, they speak English, but there's a lot of, excuse me, can you repeat that again?
Yes.
So
Luke, I was actually going to ask you, and I know it sounds kind of funny, but I often say that I had more trouble understanding the English in Ireland than I did the French in Belgium when I was living there. And it seems strange, but the Irish accent at times, I just cannot like follow it. It's just very hard. So you did experience that a little bit?
yeah, I think at least the first week, especially the deep Dublin accent, they mumble and they speak very quickly in an Irish accent. So it was every time they'd say something, I'd be like, I'm sorry. And I made the excuse, I was like, I'm actually deaf. It's clinical, like just so they would repeat everything for me slowly and loudly. But yeah, it was rough to understand. And I don't think I really like started catching everything until like the third week in.
Mm-hmm. I love that though, that you say that, you know, your ear does adjust as you are able to spend more time. You're able to do that. So that's excellent. Good. Thank you for that. Is there anyone else that I'm only calling on people who have their cameras on, but anybody who would like to add anything. I don't want to leave anybody out. Same token, I'm trying to be aware if someone doesn't have their camera on, there may be a reason that they don't want to speak. Any other comments, just general comments?
Yeah, Kimberly, I would like to add, like, if you do, you know, if there is ever like a student ambassador situation for international students in place, like, I think it'd be something that I would, you know, be involved in, just because, you know, whenever I was in Thailand, I was the only international student there, and I didn't have anybody to, you know, show me around the hospital and things. I kind of had to find my own way and, you know, try to develop those relationships with, you know, the other medical students, you know, help me on their free time and things like that. So if it is something that's, you know, that's going to be in the works, then I'd be interested.
Thank you, Vincent. You know, I have a question, because you all rotate and, you know, do rotations at our hospital, and we have our international medical students who come in. It's typically, Stacy manages this, so it's typically 5 or 6 students a month. It's a very strict schedule, so it makes it hard for us to incorporate them with some of the long-term cultural liaisons that we have. right? So we have some groups who actually like to interface with international students and researchers and scholars, but those are typically people who are here longer term, like a year, right? 5 years. When we have someone that comes in so quickly and leaves so quickly, a month, it's hard to pull them into that network. And so I'm curious, do you ever get the opportunity to interact with some of our international medical students that you see in rotations? And I'm wondering, like, now that you've been abroad, would you approach them differently when you see them at KU Med?
Yeah, I've interacted with one student, but not inside of clinic. I think a fellow medical student brought her to one of the bars that we were hanging out at, and I think it was really nice to get to talk to her and hear about her experiences. And I wish like I would have known that she was here earlier, so I could also like kind of help show her around and let her experience our culture. So
nice. That's helpful, Vincent. As you're talking, I'm thinking of ways we can just let maybe people know that the students are here, who they are, so that if you are doing something social, that you could extend an invitation. I appreciate that. Any other ideas on that?
I remember in 1 year, in 2 year, there were students, international students visiting from Spain, and Maria Alonso Loaces had them volunteering at JDoc, and met them there and like made friends, and we would like go out together. But I think if there's like a language that they like, Spanish particularly, JDoc would be a great place to show them around and meet other medical students.
It's interesting that you mentioned that, Skylar, because we have 5 students coming from Croatia in August, and they will be, one of the ways we want to loop them into the medical students is having them at JDoc. And so we're working with your executive director team of JDoc to have that opportunity for them. Again, they'll only be here for a month, so trying to get them integrated and meeting other students is kind of our goal. So if you have any ideas, because you're students, we're not. Sometimes it's like trying to figure out what works for students. It's very hard for us, knowing we don't know your schedules. We don't quite know how these things work. So if you think of something that you have an idea, please shoot me an email, because this is something that we're thinking of. And I know, like with the PT students, Yvonne does a great job of integrating them. They usually come in like 2 together, and she does a great job with that. And we struggle a little bit more with our medical students, to be frank. So any ideas on that would be appreciated. I just want to end today I won't keep you too much longer, but I did think that it was important, again, just to recognize all of you. So only a few of you were able to present, but all of you were tremendous to work with this year. I have to say that something very interesting happened with the pandemic, because we talk about being resilient and flexible when it comes to international work. Like, it's an integral, necessary part of doing international work. And so we've always talked about that, but the pandemic somehow turned a switch for everybody. And I am speaking a little bit for Alexa, but I have to say that this group of students from KUMCIO, from our PT to our 4th year medical students, you've been the most enjoyable group of students to work with. From our workshop, just your attitudes, the maturity, the flexibility, the willingness to take so much uncertainty and move forward day by day. I have been just in awe of all of you. And I think this is something that really speaks to you individually, your character, and will serve you well into the future as you continue to engage just daily in your work, but obviously if you continue in the international, collaborations and partnerships and global health. I also want to take a moment and ask all of us to recognize Alexa Smith. It takes a tremendous amount of detail and organization to do this in a year. And we say, yes, that's Alexa's job, right? That's OIP's job. But I think in the wake of the pandemic, I think we all are aware of how much extra work this took And you may not know that we were down to people in our office as well, during the pandemic. So we have 2 less, team members, and Alexa very enthusiastically, graciously, she just does the work, whatever is asked of her. She really cares so much about these experiences. And even though we had more challenges with communicating with our international partners, we had less partners, I just want to commend her on her tenacity, her dedication as well. So just a round of applause to all of you. Alexa, it's really been such a joy to see these happen and for you to go and come back and share your experiences with us. So thank you. Congratulations to each of you. You will receive a certificate that, for what it's worth. You can keep that, and please stay in touch with OIP as you progress in your careers. Remember us, connect with us. We love to hear where you are in life. Thank you so much.